I can hear us okay? All right, good. Sorry if I'm shouting or if I'm a little too loud online. Please just let us know. So as Dr. Dawson indicated, I am, I've been here with the organization. I'm sorry, I'm getting this weird reverb out of my speakers here. But I've been with the organization now 22 years, and it's been a wild ride. As Dr. Dawson indicated, there's no shortage of, it's telling me here I need to mute the audio. So let me just figure this out a second here.
If you were the test case for this.
Okay. Audio there. Sorry about that, folks.
It might be the mic that you're wearing.
Okay, sorry about that. Okay, so I've been with the organization 22 years and seen a lot of things, and I hope to find some of the topics we'll touch on today interesting. I'm an industrial hygienist. My undergraduate training was at Millersville University down near Lancaster in occupational safety and health management, and then my master's degree was down in Philadelphia. So before we really get into it, I want to share an important fire safety notice. You know, the exits, obviously, are to the back of the room. And please, 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 if there is a fire, leave the building before tweeting about it, okay? So, okay. A little disclaimer. Some of the views and opinions and concerns expressed in this presentation are mine and mine alone, and not necessarily that of my employer. So I just want to share that because I have some opinions on some things, and I don't want folks to think that that's the official hospital position. Okay, who we are at LVHN. When I started 22 years ago, this week actually, it was St. Patrick's Day, 1997, so go Irish. We were pretty small back then compared to what we are now. So back then, I recall our first year, I did the accident rates, we were like 5 million hours worked as an organization. And I just did them in January for this most recent year. We're at 30 billion hours worked as an organization. So we've grown by leaps and bounds, and it's been a very interesting journey. And we're still growing. So sometimes challenging times in healthcare, as anybody who works in healthcare will tell you. I do, yes.
Take it off. I think that's
just take it off? Okay. Okay. And folks on the webinar can still hear that? Okay, great. Okay. Hopefully everybody can still hear me. So yeah, we have 8 hospital campuses. The most recent additions to our family, I call lovingly our northern tier, Pocono, 2 hospitals in Schuylkill, and then also Hazleton, and more to come. So in addition, we have over 250 physician practice sites. We have health centers all over the place. So if most of you are from the Valley, you know of us, you know where we're at. And hopefully you've had good experiences with us, and we aim to please and take good care of you and your family. So our agenda today, we're going to touch on a variety of topics, and I'm going to start off by explaining a little bit about healthcare and how dangerous healthcare is. There's this perception I've been dealing with for the whole time I've worked here. Whenever I talk to folks and they hear I work in safety and health or industrial hygiene in hospital, and a lot of folks say, "Oh, hospitals are safe." Okay, well, let me share some data with you that might convince you otherwise. So first and foremost, work as an IH in healthcare is never dull. As this picture depicts here, this is an actual picture from our security camera where I just about had a heart attack 2 years ago. I'm walking into the ambulance and entrance at one of our hospitals, and I literally see somebody dumping sharps in our trash can. This is a regular municipal waste trash can right outside the doorway. And I wish I could enlarge it better so you could see my face, but I have that ETF look at my face. And unfortunately, it's not that uncommon of a deterrent until I actually stumbled upon it. It was serendipity that I happened to be there at the right time to see it. Sometimes members of the community think, I have needles, I have sharps, what do I do with them? I go to a hospital and dump them in your trash. This happened to be an ambulance crew that was not from the area that just thought, oh, I'll just dump this stuff in here. And not only was it was extremely unsafe and illegal what he was doing, Because he wasn't just dumping the sharps container in there. He was literally opening the sharps container, dumping the sharps container, and then using the sharps container. So that's one of those things that you scratch your head and you're like, do I really see what I'm seeing? You know? So unfortunately, this is not as uncommon as you think. You see some crazy stuff, and we were able to identify who it was and speak to his ambulance company and re-educate the individual. And I'm not aware of anything like that happening since at that location. But that's not to say it hasn't happened. You know, it can't be there 24/7. So, okay, so hospitals really are dangerous places to work. Just sharing with you first some context, a little bit of flavor or perspective. If we want to think about safe jobs, you know, typically office workers are very safe. It's the time of year we're all thinking about public accountants. Our taxes are due in a few weeks, okay? So I would think they would have higher accident rates or assault rates. When I saw my taxes this year, I didn't like what my CPA told me. So, but anyway, certified public accountants have among the lowest accident rates possible. So many of you are thinking health professionals, so you can understand the total recordable rate of injuries and illnesses is kind of the benchmark that most folks look at. BLS does a great job providing very detailed analysis of industries. So what this means is for every 100 U.S. workers, so really 100 FTEs, full-time equivalents, how many of them in a given year have an OSHA recordable injury illness? That's an injury illness that's serious enough to hit the recordable criteria. So CPA is 0.2 out of 100. Office workers, 1.3. Okay, so a little bit more dangerous. The mining industry as a whole is at 1.5 out of every 100 employees get injured every year. The national average on average for all private industry in the United States is at 2.8. So roughly 3 out of every 100 workers on average across the U.S. get injured every year. Construction workers, a little more dangerous, 3.1. Manufacturing, 3.5. Hospitals, 5.5. So we are more than double the national average in hospitals. Okay, so 5.7. We are a dangerous industry. Okay. All of that. Also, we are seeing improvement across the United States. This is the BLS total accident recordable rate, I should say, for all hospitals across the United States. As you can see, since in the past 12 years or so, steady improvement, but still a lot of room for improvement. The one lesson I want to share is that hospitals really are a dangerous place to work. As Dr. Pelosi alluded to, you name it, we have it here in healthcare somewhere. We have chemical, physical, biological, ergonomic challenges at the wazoo. On top of all those, patient assaults on staff are out of control, completely out of control. Okay, and we're challenged with it here in our organization, as are all other hospitals and healthcare institutes. It's quite the challenge, and I'll get into that a little bit more in the presentation. Okay, so what are the primary causes of injuries? What are your top 5? If we look, sharps and stick injuries have been plaguing us as a challenge. I was glad when OSHA changed their record-keeping criteria in 2001, 2002, and they made all needle sticks recordable. Previously, the only ones that were recordable is if they were clinically significant or if they had a serious exposure or needed prophylaxis, something of that nature. But it really shined a light on how pervasive the issue of sharps exposures is in healthcare. And it's still a challenge. We spent countless millions on engineered sharp safety devices, hired a professional nurse trainer. Her job is 50% sharp exposure reduction and 50% safe patient movement handling. And so we really focused on those two very intensely. Slips, trips, and falls. I'm sure many of you, I don't know what all industries are represented here, but they're a challenge for all of us. And healthcare is no different. Workplace violence, as I alluded to, it's usually in healthcare. It's usually patients on clinicians is what it is. People think that it's members, infighting between staff. It's not. It's patients assaulting staff. Material handling, of course, we have that challenge with all the logistics, all the deliveries and supplies and such. And then patient handling. Usually most hospitals, 20-30% of your injuries are going to be patient handling related. So just to give you, again, some insight into the sharps exposure story here. This is a true story. The names have been changed to protect the innocent. But this is how things can sometimes go down, unfortunately. We have a clinician, a resident, finishing up her training here with us, has an exposure during a surgery and doesn't think much of it, doesn't report it, okay? A few weeks later, we find out she's not feeling so well, okay? And she's also pregnant, okay? So then we find out she has hepatitis C, and she's more likely not to stay from that exposure. So now she has to go through the remaining 6 months of her pregnancy with hepatitis C, with the fear of God in her. Is my child going to be okay? Am I going to be okay? Okay? So the months tick by, and she delivers her baby. Thankfully, the baby is safe, does not have hepatitis C. We were able to put her on treatment, and thankfully, hepatitis C has come a long way in the past decade or so with medications, and they were able to cure her of her hepatitis C. But if you think about the agony of those months not knowing, am I going to be okay? My kid's going to be okay. So this really hits home, when you think about the toll on the workers. So one of the topics we wanted to touch on here is a lot of folks don't know what is an industrial hygienist. My mother thinks it's a glorified title I gave myself that I'm the janitor, that I sweep up industry. That is not the case. So industrial hygiene, we like to say, it's the science and the art of the anticipation, recognition, analysis, control, and evaluation. I see some people taking notes. We'll give you handouts, then I made a PDF of all the slides, so you don't have to jot this down. We'll send them out to you afterwards. But it's anticipation, recognition, analysis, control, and evaluation. Primarily, we like to say of chemical, physical, biologic, and ergonomic hazards. The definition here, I think I stole from an OSHA page. It focuses on workplace, but some IHs get really tepid when I say just workplace. A lot of IHs work outside of the workplace as well. So I just want to make sure you know they're working on environmental concerns outside of hospitals, outside of the workplace as well. Okay, as I alluded to, the big four: chemical, physical, biologic, and ergonomic. In addition, I like to throw in psychosomatic sometimes, because sometimes we're dealing with perceived hazards that don't exist, and that can really suck up a tremendous amount of your bandwidth. But we're trying to get this in a lesson format, and just people's definitions of what is an environmental hazard, it varies greatly. So hospitals, I focus on the four that I mentioned. I like to kind of bring it home to folks. ACOEM, the American College of Occupational Environmental Medicine, I believe Dr. Pelosi, Dr. Dolphin, you guys are members. They do a great job kind of bringing it home so that everybody can understand it. What are some of the top 10 that they put out a list occasionally? What are the top 10 environmental hazards? Tobacco smoke is still the top, number one. Okay, tobacco smoke is very preventable. You can eliminate exposures to that in your workplace and in your household. No revision. Radon, we are in the radon belt here, as many of you know. If you ever go to buy a home, I'm building currently a home down on top of a quarry, literally, down in Bucks County. So you can be darn sure I'm going to have a very sophisticated radon system. Asbestos, this is a topic that everyone knows. Asbestos, it's almost like a pariah. People scare the bejesus out of them. Asbestos, lead, combustion gases, tap water. Tap water's been getting a lot more attention lately, obviously, in light of Michigan and the lead issues there, combination of tap water and lead issues there, but also Legionella, which I'll touch on, and something that should probably be on your radar. Household chemicals, pesticides. We use a ton of pesticides in healthcare. People don't realize it. All these things we think with are registered pesticides, technically speaking, even like bleach and hydrogen peroxide. Allergens and food poisoning. So that's probably the only one I don't really work too much with, thankfully, is the food poisoning. We have a lot of sanitarians that work in our contracted food service provider. Other entities take a more expansive scope of what is environmental health. They would include all the ones I've mentioned so far, but in addition, when you look at the World Health Organization's definition, they also touch on climate change. So that's a topic that you're seeing more folks consider part of environmental health, whereas traditionally that wasn't the case. But that's being kind of thrown under our umbrella. I'm fortunate to have some great colleagues I work with in our environment and sustainability department. They kind of handle those issues so I can focus on injury prevention. Okay, and then that's on the slide currently the official definition of environmental health from the National Environmental Health Association. A lot of folks think industrial hygiene, environmental health questions that were a relatively new field. Actually, we've been around for at least 100 years when you look at industrial hygiene. NEHA was incorporated in 1937, so they take a fairly expansive definition of what are environmental hazards as well. Okay, so we have a ton of hazards and we want to control them. By now, most of you have all, how many here, show of hands, you've all seen the Swiss cheese model of accident prevention. Hopefully folks are familiar with that. It's basically saying, you know, these layers of cheese are your controls and your processes, and that red light going through it, that's a successful accident or a successful accident. That's when all the hazards, all your controls fail, and you have a perfect alignment and an accident occurs. So what's the best way to control them? I say add more cheese. Everybody loves more cheese, okay? So a lot of people think there's a silver bullet that, oh, we'll add a sign or we'll add PPE. People always go to PPE and signs, okay? They're the least effective of all the controls, okay? So I like to take a more holistic view. I like to add more cheese. That's the same thing I tell them when I order my pizza. Get more cheese on it, you know? So what do I mean by cheese? I mean each layer of precautions or the hierarchy of controls we're going to touch on. The more hierarchy of controls you can apply, the more you can take a systematic approach to eliminating the hazard or minimizing the risk of injury, the better off you are. There is no one silver bullet for most hazards. So I like to view the hierarchy of controls, which I'm going to explain, as the slices of cheese, and the more layers you can add in there, the more likely you're going to successfully eliminate or reduce the potential for that injury to occur. So hierarchy of controls, probably all heard that phrase that gets used in a lot of different disciplines today. In industrial hygiene, we always focus from the top down, okay? We want you to eliminate the hazard wherever feasible, okay? If you can't eliminate the hazard, we want you to explore, can we substitute? If it's a chemical that's really dangerous, can we maybe use a more innocuous chemical? Engineering controls are great. You can use containment. For instance, we use isolation rooms in hospitals. We have somebody that's a TB patient or suspect TB. We put them in an isolation room so that the air that they're breathing out with all those nasties in it doesn't go into the hallways and throughout the rest of the building. Engineering controls in a lab, you might have fume hoods or biological safety cabinets. So those are all engineering controls. Administrative controls, that's looking to change the way people are doing their job. And then PPE. Again, PPE is the very last one we mentioned because it's the least effective, all right? And you should always go to those other layers first. And I can't stress that enough. People always go to PPE and signage first. And you're really kind of setting yourself up for failure if that's all you're looking at. So some examples, substitution and elimination. As I was asked to put together a slide deck recently on this presentation, actually, a perfect example came up. Pharmacy contacted me a few weeks ago and said, hey, we're going to add this product. It's chemical been approved to add to our formulary. It's phenol, okay? Phenol is carbolic acid, very, very dangerous stuff. And they needed to add it to our patient formulary for medication because there were some people that have spasticity, they have rigid muscles and such, and a novel way to treat it is to actually inject the muscles with dilute concentrations of phenol, and it relaxes the muscles, and they can get some relief. So they wanted to add this to, and it's an approved physicians approved this. It's not like, oh, we're doing something dangerous. But when I hear we add something, I get the MSDS or SDS, they sent me an MSDS, old school terminology. You know, it's not MS. So when they send me that, and I see an 89% concentrated phenol, after I stop with my compulsions, I'm like, okay, what can we do to make this safer? Because they're initially thinking about like a leader bringing it into the organization, and then having our pharmacists dilute it, and I'm like, can we look at this and try to eliminate it? Unfortunately, you can't. You know, when the physician says we need this product, some organizations might use alcohol or something different, but the best available evidence documenting that phenol is perfectly safe and very effective. So we explored it, and the hazard, looking at the SDS and researching it some more, it runs the gamut. It's a very serious hazard, okay? But after we looked at it in short form, we realized we could go ahead and rather than bring in liters of it, since our use is going to be so low, we could at an outside instead of bringing in liters of 89% concentrated phenol, bring it in already pre-diluted down to 6% in 10 ml vials. Okay, much safer. So that's a success story where you're able to peel the onion a little bit, look at all the hazards, and try to figure out how do we manage this best. So that was a success story, and it's a good example of substitution or elimination. Engineering controls, as I mentioned, ventilation is the most common engineering control, whether it's localized fume hood or welding device, capture device, or general dilution ventilation. Process and equipment guarding, sometimes you can add guards to machinery and belts and stuff, that's a good example, or isolocks and interlocks. We have some very dangerous equipment in healthcare known as linear accelerators. Extremely high voltage, extremely dangerous. So for those hazards that folks can't get into the insides of those machines and get injured, we have a lot of isolation and interlocks and automation built into the system so that it's really foolproof is the goal there. Administrative controls, you might think of training is a common administrative control. People always run the training as well. And establishing training programs and policies. Monitoring exposure levels. A lot of times you might have programs in place and think that you're controlling it. So you want to keep monitoring exposure levels to make sure that you actually are achieving your goals. Inspections and maintenance. Some ways to double check and administrative control to make sure that your controls are still working and in place. And then installing signs. Here's somebody whispering on the webinar. So installing signs. Again, that's a frustrating one for me because everybody loves signs. I think the 5-Man electric band had it right with the song Signs, Everywhere's Signs. Come on, sing it with me. No. I'm not a huge fan of signs because there's so many signs, it's just noise. People just ignore it. And a perfect example of that is when we went smoke-free 11, 12 years ago now, indoor, we've been smoke-free at our hospitals forever, or at least for the 20-some years I'm here. That wasn't the case, though. Like 25 years ago, you'd go into boardrooms and see the physician smoking, and right, Doc? It was not that uncommon.
I never saw that.
You really? I'm told about it. I have not seen it. But no, so we've been smoke-free indoors for at least 2 decades. But we went smoke-free indoors and outdoors in 2008, I believe it was. And so, how do we communicate this to the community? Well, you put signs up everywhere. And every time we find somebody smoking, you get somebody requesting me, hey, can you put another sign here? Can you put a sign here? And this is the picture I show people now. Signs don't work. Okay? This is a individual who delivered her baby that morning and needed to smoke. Okay? So she's out there leaning up against the sign smoking. So, yeah, if you think signs are effective, I have several pictures like this I can share with you. So they just don't work. So please stop thinking that you solved the problem. So, okay. And the last of the hierarchy of controls, which again, they can work extremely well, but I want you to look at them last. PPE, let's go to PPE last. After we've done all those other things, that's when we look at PPE. PPE, traditional PPE, I'm sure you use them in your industries. We use a lot of respirators in healthcare, tons and tons and tons of N95 disposable respirators because of all of the infectious concerns, and gloves. Oh my gosh, I wish I had stock in a glove manufacturer because we use gloves like you can't imagine in healthcare. Safety glasses and face shields and protective coveralls and protective aprons and gauntlets. The full gamut of PPE. It can be very effective, but I don't want you to think that let's go there first. Let's go there last. Let's go there after we've done everything else, please, and you'll have a much more effective program. Okay. Sometimes people don't have PPE that they need, so they improvise. Okay. Fortunately, we have the PPE we need, usually always available to us. We've had some shortages when there's been influenza pandemics and such, but you can see around the globe, people aren't as fortunate as we are, and they'll improvise. They don't have a hard hat, okay. So availability can be a concern, and maintaining PPE. When you see somebody wearing a hard hat that looks like that, do you think that's going to protect you? I mean, obviously it protected him several times, but your luck's running thin, buddy. Okay. So we always encourage people to inspect your PPE and, please update it periodically. If there's any dents or dings in your hard hat, you need to replace it. That's a dead giveaway. Somebody needs to take that hard hat off and discard it. And again, people don't always wear it properly, okay? You can see the earplugs dangling there and the hard hat. Not going to do a lot of good if you're not wearing it properly, okay? So don't just assign your people PPE. Monitor. Get out there. Inspect. Go to the Gemba and watch your people doing their job and make sure they're wearing that PPE properly. Earplugs is a challenging one. Everybody wears earplugs wrong. I mean, more often than not, when you see people wearing earplugs, they're hanging out like half an inch. So when you see people with earplugs, please take the time and educate them on the proper way. By now, any of you that have earplugs, you teach them to lift the ear, you open up the ear canal, you make sure you squeeze the earplug properly, stick it in, and if it's sticking out a half inch to an inch, it's not in there properly. It's not providing the noise reduction rating that you think it is. So really, earplugs is, I annoy the groundskeepers because even though they're not my employees, they're not, contract out the services. I keep PPE in my truck, and when I see, the guys cutting the grass and stuff without the safety glasses on or the earplugs, I'll go up to them. Hi, my name's Tim. I'm concerned about you. Can you please wear this PPE? And I have them over there. I know you have them, but you're not wearing them. So yeah, please get out there, watch what your people are doing with PPE, and make sure they do it. And the reason it's such a challenge with PPE because really nobody likes wearing PPE. My dog reminds me of that every time I try to get her harness on. And, really, nobody likes wearing PPE. A lot of it can be uncomfortable. They've made a lot of progress, though. I will say, from the time I was in college, I remember taking chemistry classes and those horrible goggles that you used to have to wear that everybody hated. They've come a long way. I mean, the comfort factors for PPE, I will say in the past 10, 15 years, has really come a long way. So if your only frame of reference to goggles and stuff is what you wore in college chemistry class, it's really much, much better, and encourage you to buy the good stuff. If you want your people to wear it, spend a little more and they'll actually wear it. So, okay, so the types of physical hazards I want to just touch on: temperature, radiation, vibration, and noise. Noise we deal with a lot in industrial hygiene. I don't personally deal with that too much in healthcare for employees. I mean, you have medevac employees with a lot of noise exposure, ambulance employees. We used to have a cabinet shop where we had some noise levels and boiler plant. But outside of that, usually up on the units, there's thousands of alarms a day, but they're not above anything that would cause hearing loss. They're a safety hazard, in my opinion. All the alarms, they put alarms on every new piece of clinical equipment nowadays. And the cacophony of sounds up on the units can just drive you nuts. It can drive the clinicians nuts, and it can drive the patients nuts. So I just want to give you an example of how we've applied the hierarchy of controls to addressing what's not really a safety concern as much as it is a patient satisfaction concern. So just to give you an example, you can use this hierarchy of controls, this methodology, process safety methodology, outside of safety concerns. So the patient satisfaction example I'd like to share with you, how we use the hierarchy of controls to address this in our organization. About 10 years ago, healthcare was started to be challenged by the federal government. Most of at least half of our reimbursement comes from patients that are on Medicare, Medicaid. So the Centers for Medicare Services said, you have to start surveying your patients. So we're not only going to look at your clinical outcomes, we're also going to look at your patient satisfaction, and that's going to impact your reimbursement rates. So they gave us a series of domains that you have to query your patients when they are discharged on. And one of them, they initially asked the question, you had to use their exact wording from CMS, Center for Medicare Services, was during your hospital stay, how often was the area around your room quiet at night? Okay? And the only one that you get any credit for is if they say always. So always is a pretty tough bar, okay? Always. Think about always. How many times can you say always on anything? So that's the only one you get any credit for. So even if 95% of your patients said usually, you get no credit for that. You actually get an adverse impact on your reimbursement. So they have to say always. So how do we get there? It's not just because CMS is driving this. We've known forever. Over 160 years ago, in the seminal work, Notes on Nursing, everyone knows Florence Nightingale. She's like the premier best nurse ever. I mean, she kind of really founded the modern day nursing programs. And she wrote the book, Notes on Nursing. And in that book, she said unnecessary noise is the most cruel abuse of care that can be inflicted upon a patient. Okay, so all those sounds, we know it. When you're not feeling well, noise is amplified. Everything annoys you. I mean, so unnecessary noise, it is cruel, and we need to do a better job eliminating. And by no means have we slayed this beast in healthcare. But we're making progress. Little things you can do, like engineering controls. We took those buttons. Everybody likes to hit those buttons at all the doors. We've eliminated most of them. Okay, well, I still find some sometimes. I get it out of here. So we get touch-free ones. That's not only a noise reduction improvement, it's also a hygiene improvement. All those fomites, touching surfaces, get rid of them, okay? Another example where at this campus, we were having a ton of code blue false activations. The button there on the left, many of you that are human factors specialists or have training in ergonomics, you can see why that might be a problem. They put the code blue buttons in this new beautiful tower that we're in. They put the code blue buttons right next to the switches. So in the middle of the night, when the patient or staff member is fumbling for the light switch, they hit the code blue button by accident. It was, so when I got into it and learned about it, okay, we put a control, put a little protective cage over it, that little plastic polycarbonate. So we went from many of these a year, I think it was 30 in our worst year, to like 0. So that's a successful engineering control. Awareness, getting the word out. A lot of people just never thought about it. Oh yeah, it does have an impact on our staff members, their stress levels, their cortisol levels, everything gets out of whack when they're exposed to too much noise. So it's harmful to our patients and to our staff. Other things we've done, signage, okay? We didn't go there first. We did add signage though, just to polite, gentle reminders. A lot of times family members come in and they're anxious, they're worried, they're concerned. They don't realize how loud they're being, okay? So just try to raise awareness. So we got pictures of cute kids and try to remind them. We used lean methodology and created A3s. We targeted the top 10 units with the lowest scores relative to patient satisfaction and noise. And we went into those units, measured noise levels, and we looked at all the assorted factors on those units. We created A3 documents. You guys familiar with A3, lean methodology? Training, we made just-in-time training programs that we deployed strategically, 50 PowerPoint slides, interactive slides, educating staff on those things. Earplugs for the patients, okay? Unfortunately, I think we have 1,900 patient rooms. Not all of them are private, okay? So, for instance, when my mom was a patient in one of our units, and 3 feet away from her is another bed, and they have their children in the room at 3 in the morning, and they're playing video games, and my mom's trying to sleep, there's not a lot you can do about that. Healthcare about 20 years ago started saying, no visiting hours. Everybody can visit any time, and that's what society kind of forced on healthcare, that you had to eliminate visiting hours and let people come whenever they want. And I think it's really gotten out of control, because my mom shouldn't have to have little kids in the room at 2 a.m. when she's trying to sleep, playing video games or watching SpongeBob. Nothing against SpongeBob. Great stuff. So at least as a last line of defense, we could empower, and when that patient is restless and the noise in the hallway or from the patient next door to them is bothering them, we can empower them and give them earplugs so they have some control over their exposure. The other thing we did is the call bell or pillow speakers that the patients have, we switched them all out. And previously we didn't have headphone capability, so we switched them out so that we could plug headphones in. So your patient, you don't have the 2 patients in the same room battling the TV. So if you want to watch TV at 12 o'clock at night, okay, we politely ask you, please, out of respect for your roommate, please wear headphones. So that's helped out tremendously. Other engineering controls, a lot of times people want the door open. The nurses want it open so they can check on their patients. So we switched out some of our doors, and we're doing it more and more so that they can still check on their patients with the door completely closed. You know, closing a door is an excellent way to reduce the hallway noise from getting into the room. So by getting doors that they can still check on their patient and then close the blinds that are in the door to protect their privacy, that's a good way that we could reduce noise. And then, again, kind of PPE. This is not a joke. In our NICU unit, neonatal intensive care unit, you have babies born extremely young, extremely fragile, very sensitive to the environment. We're doing a huge construction project now near our neonatal intensive care unit, and to make sure that the vibration and all those things are under control, and especially their noise exposure, to address their noise exposure, we're doing everything we can with the contractors, but as a last line of defense, when we know they're going to have to jackhammer or something, we have actual earmuffs for the neonates that can be worn, and they're very effective. So applying the hierarchy of controls, how do we do? We increase patient satisfaction relative to noise 25%. Okay, so still a long way to go. It's still the biggest challenge on these surveys that all hospitals must do. Patient satisfaction with noise is still a laggard. It's still an outlier. It's still usually your lowest scores, but a 25% increase is huge. Moving the needle 1 point on these surveys is a challenge. Moving it 25% is a huge accomplishment. So while there's still a long way to go, if I can wave my magic wand and make all private rooms, I would do it, okay? But the reality of it is, with new hospital patient rooms costing at least $1 million a piece to build, we're not going to get to all private rooms overnight. We're getting there. We're adding more and more, but it's going to take at least another decade, in my opinion, for most hospitals to get there. Okay, so moving on, biological hazards. Just to give you some examples, insects, you might have your staff get exposure to insects as a biological hazard. Especially, I think of all the folks working on the grounds crews pulling weeds and things, a lot of exposures to poisonous plants. Animals, at a previous employer when I worked at AT&T, we had snakes at our campus, and folks, somebody got bit one time by a snake. Bloodborne pathogens, I deal with that all day, every day in healthcare. And then another one is water and sewage. So I wanted to peel the onion a little bit and share with you an emerging hazard or biological threat. And I won't say it's emerging as much as there's getting increased recognition. Okay, it's always been there. Legionella, it's getting a lot of press lately, and there's a reason for it. If you look, there's been an alarming uptick in Legionella cases identified in the United States. Okay, whereas in the year 2000 we were a little over 1,000 cases reported annually across the United States. I think last year we were over 6,000. So I mean, it's gone up skyrocket. And again, I don't think that means that Legionella wasn't there before. It was there before, just people weren't looking for it. It causes pneumonia. It's bacteria that's ubiquitous. It is in your pipes. It is in your lakes, rivers, soil. It's in your municipal water supply, and we know municipal water supplies have such an aging infrastructure. The older the pipes with all that rust and stuff, that makes biofilm just go wild. Hot water systems are your biggest risk because Legionella doesn't do so good at 50 degrees and below, 60 degrees and below. But when you get in that sweet spot around 100 degrees, Legionella really takes off. Whirlpool spas and decorative fountains, that's another big risk. We've banned all fountains. Designers, architects love putting fountains in hospitals. And I'm pleased to say that we were ahead of the curve on this one. We banned them at least 10 years ago. So we don't allow fountains. Locally, I can tell you, many of you probably recall just 2 years ago, probably 3 years ago now, a health center here in the Valley, a medical office building, not owned by us, but we did have an office in that building. They had a massive fountain, and there's a gym there, and a lot of members of the community go to that gym. And right when you walk in, you got a 20-foot wide fountain. You got lights in the fountain, okay? Lights making warmth. You got soil because they had potted plants in the fountain. You have a perfect little broth of stuff growing there. And unfortunately, 6 fairly healthy people that were going to the gym and stuff in that building did contract Legionella tied to that building. 2 of them died. So it's serious. So if you have fountains, if you have these things in your workplace, everybody thinks they're being maintained properly. They're almost never maintained properly. So if you can eliminate them, or if you have to have a water feature, they have now sealed water features. We've added a sealed water feature. It's the only water feature I know of in our organization. I never pretend to know everything that exists because it's millions of square feet. But in our Health Network Labs site, we have a beautiful wall feature now. It's sealed in glass. It's completely sealed, and it's bubbles that go up the wall. So if it's completely sealed, that's one thing. But I really would caution you, please, if you have fountains in your workplace, if you have whirlpools. A lot of people think, okay, that's mostly a healthcare risk. It's not. Most outbreaks are not in healthcare. Overwhelmingly, most outbreaks are not in healthcare. You all have cooling towers, right? Cooling towers are a huge risk. 85% of cooling towers, just this slide, I'm sorry, I forgot to mention, there is a seasonality to Legionella. Last year we had a ridiculously hot and wet summer, okay? So we had the worst year on record in Pennsylvania for Legionella. I mean, it was just gangbusters. It was really terrible. So there's a seasonality to it. Also in the winter months, you don't tend to deal with it as much. It's mostly in the spring and summer when pipes warm up. Cold water pipes that are not normally a risk are warming up because they're near, they're not insulated properly or whatnot. So Legionella, again, it's in pipes. It is, the more you test, the more you will find it. It grows best in complex pipe systems, okay? Hospitals have very complex piping systems, okay? If you're a one-story office building, your piping system is not that complex, okay? You still have risks that I'll touch on. But if you have 8 stories, 10 stories, and pipes that go everywhere, you have more risk. Ships actually have a much higher risk of Legionella as well because they have very complex piping systems. What are the risks? Cooling towers, showers. The showers, you can drink Legionella actually, and it's not going to usually have an adverse impact on you. You have to aspirate Legionella. You have to get it into your lungs, and you get it in your lungs, and then you get a pneumonia. So showers are a very effective method for aerosolizing. When we aerosolize things, it becomes very easily to aspirate or inhale that. Hot tubs are perfect. I mean, hot tubs are poorly maintained more often than not. So check your hot tubs, check your fountains. And again, there's personal risk factors. You know, many of you probably recall Legionella was kind of first discovered down near Philadelphia at a Legionnaires convention. And that's what it's named after, is Legionnaires disease is named after that convention. And so there are risk factors such as smokers. Smokers are much more at risk for Legionella. Gets into the synergistic effects of, you know, you combine personal risk factors plus an exposure, and, you know, they're ripe for getting Legionella. People with weakened immune systems, many of the people we treat in healthcare come to us with weakened immune systems, so they're vulnerable to begin with. And then chronic diseases. If people have chronic diseases, they're at a much higher risk. People over 50, also much higher risk. So again, it's on the rise, not just in terms of the number, the raw number, also the rate of Legionella being discovered or diagnosed in the United States is really skyrocketing over the past, 18 years or so. This slide just points to, again, it's not just a risk in hospitals. 84% of cooling towers throughout the United States have Legionella in them, okay? So you have cooling towers probably more likely than not at your place of business. So I ask you, please, please, please check how well they're being maintained. They should be doing dip tests on them to measure bacterial levels. They should be cleaning them at least twice a year, cleaning out the sump. Your drift eliminators on your cooling towers to prevent those mists from coming out and possibly being inhaled. There's things you can do, okay? And there's some good guidelines out there, which I'll share with you on a future slide. But please look at your cooling towers, and don't just ask your engineering department. Go out there and physically talk to them and make sure we found opportunities for improvement in our programs the more we peel the onion. So please get out there and look at your cooling towers. Talk to your maintenance folks. Don't just say, are you maintaining them properly? Oh, yeah. No. Show me what you're doing, okay? Okay, in pipes, you have Legionella can come in through the water supply, okay? And that would be your free-floating in the water system. But then what happens is it colonizes a biofilm that's in all your pipes, okay? And Legionella is then protected. and it grows in that biofilm, okay? So it's a challenge. You can treat it with heat or shock treat it with heat or chlorination or monochloramine. There's different things you can do. Moving on to the topic of Legionella, another lesson I wanted to share is always think about the unintended consequences of your actions. A perfect example of this is how many of you see the two faucets here? The faucet on the left is the traditional manual wrist blade faucet. The one on the right is the motion-activated faucet. How many of you would think which one's safer? You know, which one from a hygiene perspective? Most of us, myself included, you know, several years ago, 5 years ago, 10 years ago, when these started becoming more readily available, we're like, oh, we got to go motion-activated. Go motion-activated. It's a no-brainer. I'm here to tell you, they are not better, okay? And why is that? Johns Hopkins did a study, and many other organizations have replicated this study. And when you look at the motion-activated devices, they are colonized with Legionella and other nasties, like way, way more than manual faucets. They have a ton of parts in them, little rubber gaskets and things like that, that Legionella and other nasty bacteria like to grow on, okay? So while you think you're improving hygiene by going touch-free, there's a place for it. But if you have high-risk patients like we do in hospitals, we're now taking these out across the board in our patient units. The other reason, so they grow stuff way more than manual faucets. I think, I'd have to refresh my memory, I think Johns Hopkins found like 4% contamination rate in their manual faucets and like a 50% contamination rate in their touch-free faucets. So it's a huge, huge difference. They grow stuff. And part of the reason for that is, you know, we all want to be more green and environmentally friendly. Well, these faucets, they use so little water that there's not enough scouring action, so you don't reduce the biofilm, okay? In addition, they use so little water that that water sits in the pipes much, much longer. And what we know is that as water ages in a pipe, you know, if we used to flow, you know, 7 gallons per minute through that pipe, and now we're doing 0.2 gallons per minute, as water ages in a pipe, the chlorine, the disinfectants that the municipal water supply adds, they degrade. So those things get so efficient at conserving water that when we go measure the chlorine levels, there's none, no detectable, because it was just too efficient. That water sat in those pipes so long, there's no chlorine left. There's nothing left to disinfect and kill the Legionella. So we are in the midst of a huge capital project. These units, some of these units were only built 3 years ago, okay? So to go and take out 1,000 faucets, electronic faucets, it's no small undertaking. You know, when you add 1,000 faucets, $1,000 a piece to take them out, I mean, it adds up real quick. So we're going out and we've changed our specs. No longer build hospitals. No longer is that the standard. That'll be the exception. Maybe in a public bathroom it might be acceptable, but in the Department of Health makes us put sinks right by the patient's head in new hospital rooms. Okay, so you had a perfect exposure potential there. So think about the unintended consequences. I was one of the biggest champions for touch-free faucets. I'll admit it. Okay, I didn't think that through. Other things that we might not think of. How many of you have ice machines in your workplace? Okay, you're thinking, oh, we have an office park. We have ice machines. We're not at risk. Again, I want to challenge you. Ice machines, many ice machines, none of us like the taste of chlorine in our coffee. I'm a big coffee drinker. I'm an addict. My name's Tim, and I'm a coffee addict. Okay, so I will tell you right now that a lot of these ice machines and water filtration systems that we add to make that coffee taste better, how are they making it taste better? They're stripping out the chlorine, okay? You put an activated carbon block on the water supply right at the machine, you're stripping out the chlorine so that it doesn't impact adversely the taste of your coffee, okay? But what are you doing? You're stripping out the chlorine that's protecting stuff from growing in your ice machine, so then you get stuff like that, okay? That's a real picture I found in a physician practice, not one of mine, thankfully, but I'm a nerd. When I see things, I go up and I poke my head up, poke around. So I can't help myself, okay? So I challenge you, please look at your ice machines. And you might say, okay, we're not getting rid of the carbon filters. I am not drinking chlorinated coffee, okay? Fine. Make sure your maintenance is up to snuff then. Ice machines often get overlooked. They often get overlooked. Most manufacturers require that you give a thorough completely break it down, disassemble it, decontaminate it, and reassemble it every 6 months. Outside of healthcare, most places are not doing that. And and even this one was maintained at least every 6 months, and that simply wasn't enough. So I gently advised them, you might want to consider increasing the frequency of cleaning and those kind of things. So there's some nasty stuff that can grow in them. Why is that? You're thinking ice machine, it's cold water, it's not at risk. Well, you have a perfect recipe there for growing stuff because, yeah, the water's cold coming into the machine, but it sits by the coils in the ice machine, warms up, okay, and it gets in the perfect temperature range. So it can really grow some nasty stuff. So please look at your ice machines, regardless of whatever industry you're in. Okay, all is not lost. The CDC came out with what I personally feel is an excellent resource on Legionella, and not just for healthcare, for everybody. And I have the link there, which will be in the slides that I hand out at the bottom of the page. And it's 36 pages. It's written in layman's terms. You don't have to be a biologist to understand it or follow it. It's very, very well done. Very common sense approach to maintaining or reducing your risk of Legionella in your workplace, in your home too. Again, if you have hot tubs, I have a hot tub at home. And as I learned more about Legionella, I took cleaning it more thoroughly, changing the filters more often. I took it a lot more seriously. Okay, so while we're on the topic of biological hazards, no industrial hygienist presentation would be complete without mold, okay? And that brings me to a lesson I wanted to share, which is just because you can test for something doesn't mean you have to test for something, okay? One of the most annoying requests you get is, can you touch the air? Can you touch the air? Every office worker thinks they're dying of air quality. So I don't have to test the air. When I go into a building and we're doing our due diligence before we buy a place and I see something like this, I don't have to spend thousands of dollars to test the air. This is a picture I actually found in a place that we were looking to purchase a practice. The picture on the far left, I took that one. The other ones I stole from the internet. But I don't have to test that. I know that's a mold problem. You got a mold problem, you got a moisture problem. I don't want to spend thousands of dollars testing it. I want to spend thousands of dollars resolving it. And not just cleaning up the mold, but getting at the root cause. If you clean that up, and too often we see this, people clean up the mold and they don't address the root cause, which is the moisture getting into the building, because that's a harder one to solve. Oh, you mean I got to pay people $30,000 to come out and seal the exterior of the building where all the water's getting in? Yeah, you do. Because if you're going to spend $10,000 to clean up the mold and you didn't address that, guess what you're going to have a year from now? So another thing I'll mention while on my lecture about mold, if you have in your offices, at your homes and stuff, wallpaper on exterior walls is a perfect recipe for inviting mold growth, okay? Wallpaper acts as a moisture barrier, and the adhesives in the wallpaper, once they get wet and that moisture comes in and out of your walls all day, every day, your exterior walls, okay? So when you put that vinyl wallpaper up, it's the worst. Now you've put a perfect water barrier there. That moisture can't get out and the wall can't dry out, okay? So wallpaper on exterior walls is inviting growth, okay? Especially if you don't have well-sealed exterior walls. So yeah, don't just knee-jerk reaction, let's test for mold. If you know you have a problem, if it's obvious, if you see it or smell it, you don't have to test, okay? It's worthless data. This annoys me. Some of my industrial hygiene colleagues that are consultants, they go out and really do a disservice to companies when they make them spend thousands and thousands of dollars doing unnecessary testing. You don't have to test it. Let's get at the root cause. Your money's better spent fixing the problem. So can I test the air for mold? Yes, I can. But as you know, there's no permissible exposure levels for mold. There's no consensus on what is a problem level, what is a danger level, what is your hazard threshold. The accuracy and precision of mold testing is very poor. It's poor at best, okay? You can have replicate samples, 3 samples running in the same room at the same time and get results that are orders of magnitude difference. So I'm not a huge fan of mold sampling. I just don't find it has much diagnostic or probative value. Just terrible accuracy. You can have different labs analyze the same sample and get orders of magnitude interpretations. So, you know, what are we doing here? So yeah, just because you can test doesn't mean you should. I'm very pleased and very proud, our friends at NIOSH, recognizing that there's a whole industry out there that's this mold is gold industry that tells everybody test, 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 test. testing, personally, I think it's fairly worthless, no diagnostic probative value. In recognition of that, NIOSH came out, NIOSH is a division of CDC, they came out with a really excellent guideline. Again, easy to read, easy to digest. The link is in my slide there. They came out with this about 2 months ago, and they kind of say it best here. Researchers have not found exactly how much exposure to dampness-related substances and mold it takes to cause health problems. Studies report that finding and correcting sources of dampness is a more effective way to prevent health problems than counting indoor microbes. I couldn't have said it better myself, okay? So really focus on correcting the dampness, correcting the water intrusion. If you have water intrusion, if you don't have mold yet, you're gonna. So be proactive. When you see those wet ceiling tiles, that's a courtesy reminder, we got to do something, okay? So I kind of like it when I see a wet ceiling tile because, okay, I can go there and I can pop the tile and I can see, oh, wow, we have a leak here. And leaks are a challenge. Sometimes leaks coming in on the first floor are coming from the fifth floor, coming from the facade. I mean, leaks can be a real challenge to trace. But focus on eliminating the moisture problem and less testing. Okay. As we're getting towards the end of my presentation here, where are we at on time? Okay, I'm going to start winding down a little bit, but I wanted to share with you the top 10 OSHA citations, and I don't want to step on any toes here. We have some distinguished OSHA colleagues here, but I think it's a good reminder to folks to see what are the things that are most getting attention nationwide. The top 10 is fairly consistent. The top 5, actually, I think have been the same for the past 5 years. Fall protection, hazard communication, scaffolding, respiratory protection, lockout, tagout. So the top 5 have been, I think, identical for 5 years in a row. Then number 6 is laddered, powered industrial trucks, your forklifts and things of that nature, aerial lifts, fall protection, machine guarding, and PPE. So 3 of those are squarely under the domain of industrial hygiene, and nowadays more IHs are dealing with all of them. I mean, I don't have the luxury of just saying I only do industrial hygiene. As the safety director here, I deal with all of these concerns. So that's for all industries across the United States. I thought it would be helpful to give you a tool when I talk to folks to say, do you know what your top 10 or most frequently cited things are in your industry? A lot of people are like, I don't know. So I wanted to give you a tool. OSHA has a great tab, a great web page, and I have the link to it in the handouts. And you put in your industry, your NAICS code, or your previously us old school folks called it the SIC code. It's now the NAICS code. And if you don't know it, just leave it blank, and a bunch of drop-down boxes pop up, and you can pick which is your industry. So that's the link there. You go to that link, and you figure out what code is for your industrial sector, and it'll populate what were the most 10, and it's not stale data. It's the most recent fiscal year. So the OSHA federal fiscal year, I think we're federal fiscal 19 now, right? So federal fiscal 18 just ended in end of September. So that data is like out there real quick. Within a few weeks, they had it all populated. And you can see this is just an example. Construction is the one I put up there. Fall protection, $34 million in fines last year. $34 million in construction for fall protection, okay? So clearly, if you work in construction, that better damn well be at the top of your radar. Because if it's not at the top of your radar, it's at the top of OSHA's. And there's a reason. OSHA has very strategically, they don't just go out and just cite for the sake of citing, okay? They're trying to drive home the message here. You got to take these hazards more seriously because that's the bolus of where your risk lies in those industries. So just please go back. If you don't know what's being cited most in your industry, use that tool. It's a great tool that OSHA provides and very current, timely information. So a little plug for our friends at OSHA. And winding down now, we thought we might share with you what keeps a hospital safety director or hospital industrial hygienist up at night. Okay, so hopefully you find this amusing or interesting. If not, so be it. It's usually, for me, I like to be in control. I like hazards that I can manage and feel that I'm in good control of. And when things feel like they're out of my control, that's out of my comfort zone, as it is for most folks. And so kind of the 3, when somebody asks me what keeps me up at night or what do I worry about, these are the ones that come up top of mind to me in healthcare. Even though workplace violence is relatively small percentage of our accidents. It's less than 10% of our accidents. The emotional impact on your staff and the severity of these incidents can be so traumatic that it bothers me. It really bothers me a lot, and I think of workplace violence. And sometimes you feel kind of helpless because at this campus, actually in our emergency department in 2017, we had a colleague of ours stabbed in the neck. And he was stabbed in the neck with 2 security officers less than 60 feet away from him. And we have a ton of controls in place. We have workplace violence programs. We have robust programs in place. This guy, when you have a determined assailant, they can really cause a lot of damage, and despite your best efforts. We have a workplace violence committee. We met yesterday again, and our security director, he's a retired cop, 25 plus years, I think, on the force, was police chief. He said reducing violence in healthcare is far harder than it was in the general community because our hands are really tied. I mean, we get patients that we can't turn away. And on any given day, we have 18 to 20 clinically psychotic patients, okay? 18 to 20 clinically psychotic. And I don't mean to imply that every psychotic patient is violent, okay? But many of them can become violent like that. Could have been sweet as can be 6 days in a row. Then next thing you know, out of nowhere, bam. So some of these patients are really super predators in my mind. I mean, you can have one patient. We have one patient we've been dealing with, injured 6, 7 staff members. You're not allowed to use any physical restraints or Department of Health, CMS. You're not allowed to use restraints. People think, oh, just put them in restraint. It's almost impossible to put them in medical or physical restraint. And you can't turn them away. You can have someone that hurts countless members of your staff, and there's no place to go. We've closed most of our mental institutions in the United States, so they're all out on the street. They're in the community. They're living in our neighborhood. So workplace violence is a real challenge. I wish we had better answers. We have very robust controls and layers, more cheese, as I like to say. We keep applying and throw more cheese, more security guards, more cameras, more locks, more controls, more secure access. And damn it if they don't find a way to defeat your controls. So it's a challenge. When he got stabbed in the neck, and I went to go see him that morning, when you saw where the stab wound was, right on the spine, I thought, how did he survive this? This is very emotional for me. So another challenge in healthcare that keeps me up at night is protecting people from themselves. And then the worst one for me, like the kind of worst case scenario, is a global pandemic. I really kind of worry about that, and I'll tell you a little bit why. So getting into it, again, healthcare, we know we're seeing more and more violence in healthcare. Healthcare makes up only 20% of the injuries. Healthcare is a massive, massive industry, okay? It's the largest employment sector in the United States now. It surpassed manufacturing and retail last year, I think it was. And so healthcare makes up 20% of your workplace injuries, but 50% of your assaults, okay? So healthcare, again, patients, it's not staff members hitting other staff members. It's the patients. And some of them are psychotic, behavioral health issues. Many of them, it's your mom. It's your sweet mom with dementia that beats the crap out of the nurse unexpectedly out of the blue. When she's been sweet, she's been with us 10 times in the past 5 years, never had a problem with her. Then out of the blue, she bites the nurse that's, leaning in to, take her blood pressure or something. So very challenging. 2 million workers in the U.S. are victims of workplace violence every year. Numbers just going up. And homicide is the 4th leading cause of workplace death. Think about that. That's kind of scary. And in addition to the human toll, you have the huge financial toll. I focus on the human toll because costs, we can make more money. You can't, some of these damages to our staff members are lasting psychological wounds and lasting physical injuries. OSHA did come out with many publications actually in the past 5 years as this is kind of hit, really OSHA, I think, hitting their stride with coming out with good guidelines and recommendations. But even when we're applying all of the recommended controls, we can still be defeated sometimes. And so that is a challenge. Frustrating for me is protecting people from themselves. More and more we see people, and I'm guilty as charged. I don't want to pretend, I never do that. I do that. We all do that, okay. We're seeing more and more injuries from people not being cognizant of their surroundings. We're seeing we're all kind of addicted to these damn things in our pocket, and we pick it up dozens of times a day, and we're constantly tied to it, and we're distracted more often than not, and we're seeing it show up. And you see people crossing the streets all the time. I mean, go to New York City on any given weekend, and I go out with friends and visit. I kind of like to people watch, and you see it's more people than not are on their devices. On my way over here this morning, stopped at a light, car pulled up next to me. There are 4 people in the car. All 4 of them, including the driver, are, it's like, God, so I try to disengage and keep this thing off. Take Facebook, take those things off your phone. It's not important. It's not urgent, okay? So if you don't need it, I have that stuff on my iPad at night, and I can read that junk. We are seeing it show up in accident rates, too. The National Safety Council, other entities that look at it, we're seeing more pedestrian deaths, people getting hit by cars, and it's not just kids. People think, oh, it's kids. No, it's adults. More children that are 12 to 19 are getting hit by vehicles than toddlers. When you think of kids getting hit by cars, you think, oh, kids going to run out chasing a ball. No, it's more kids getting hit by cars because they're not paying attention to what they're doing. Other things people frustrate is when people don't use any common sense. When you have a perfectly paved, perfectly shoveled, perfectly treated surface, and they decide, I'm going to climb Mount Everest and go down this hill here full of snow. Just this past month we had that. We had a very serious injury, and very frustrating for me because we were there. I mean, the surfaces were perfectly clean. She chose to take a terrible shortcut down, and it was February 13th, the morning of that ice storm that covered the valley with a 1/4 inch of ice everywhere. And if you're deciding now's the time I'm going to climb down a snowbank, how about using some common sense and stick on the trail? Is it worth it? Because now we got a compound fracture and very serious, very costly, very painful injury. So that frustrates you because we literally employ an army out there working 24, 36 hours straight, dozens and dozens of people maintaining the campus, and then you have people doing things like this. We're seeing more people getting injured walking down the steps, again, because they're distracted. Some people, I spoke to a lady that got injured in the stairwell. She exercises going up and down the steps during her break. Okay, that's good. And fell down, looking at her phone. So one thing I want to share with you, a video. Let's see if this works. So I share that with you. I think it's a powerful video, and I would ask you to consider sharing that with your staff members because it kind of drives home the point in a little bit of a humorous way at first there, and then gets a little dark at the end, but kind of really drives home the point. It's true. I mean, we're seeing way too many motor vehicle accidents due to distracted drivers. I personally came upon a lady that spent, I think, 8 days in her ICU. I was the first on scene. She rear-ended a bus right in front of Dorney Park, and literally happened. I didn't see it happen. I was coming around the bend, but when I went up there, she rear-ended a bus and was very seriously injured, and she was texting. So yeah, just we're all guilty of doing things we shouldn't do, especially the walking and reading and stuff on our phones. But please share the awareness that this stuff is having its impact. The last thing that I wanted to share that keeps me up at night is like a global pandemic. Okay, and when you think of global pandemics, the benchmark for the worst pandemic ever, people think the Black Plague. No. The Spanish influenza of 1918, 101 years ago now, by far the worst pandemic ever. Estimated 50 to 100 million people succumbed to the Spanish flu. Okay, 25% of Americans contracted the virus. Spanish flu killed 57,000 American soldiers. That's more than died during the entire World War I, okay? And 675,000 deaths in the United States alone due to flu, okay? Over 195,000 fatalities due to the flu in America in 1 month, okay? It spread so intensely, healthcare workers became sick during their shift. There's some great articles on this in the Morning Call and other outlets. One that I read that described it was blue lips, blackened skin, blood leaking from noses and mouths, coughing fits so severe they ripped muscles, crippling headaches and body pains that felt like torture. People would wake up, feel fine, go to work, and be dead by nightfall. I mean, that scares the crap out of me, okay? To think something like that, when I saw the global response and our government's response to the Ebola epidemic in 2014, that really made this top of mind for me. The flu targeted the young and healthy. The elderly with maybe less active immune systems kind of were not spared, but they didn't get it as bad as the young, healthy with really robust immune systems, because their immune systems went into what's called a cytokine storm. The docs here can explain it better than I, but they had a robust immune system and it went haywire. So in my opinion, this is just my opinion and I'll preface it, having lived through healthcare's response to the 2014 Ebola outbreak, I think healthcare, I think our government, I think the World Health Organization, we are grossly unprepared for a pandemic of that scale. We don't have the resources, we don't have the stockpiles, we don't have the knowledge. We became a CDC designated Ebola center at this campus. We spent over $1 million to build, and we did it in rapid, unbelievably rapid timeline. When Ebola hit and it kind of first got on our radar in 2014, it was simmering over in Africa, okay? And the president, our leaders, and CDC, Tom Frieden, in the unlikely event it comes to our shores, they were saying in September, you know, we're educating hospitals, we're going to be okay, we're prepared. Okay, so in the unlikely event it hits our shores, within 2 weeks it hit our shores, okay? A gentleman flew here from Liberia with Ebola. Nobody knew he had Ebola, but we had a very robust control. We asked people politely leaving Liberia, were you exposed to anybody with Ebola? Well, no, I was not. Okay, get on the plane. So he gets on the plane, flies to Dallas, and before you know it then, we got healthcare workers contracting Ebola in the United States, okay? How could it happen? Before any root cause analysis comes out, like as soon as the news reports were coming out that a nurse got it, the head of CDC is out there blaming it on lack of adherence to controls. You know, throwing this nurse under the bus that she must not have used the proper controls, okay? So that, I will tell you, the only time I've seen nurses cry in my 22 years in healthcare was when we were preparing for Ebola. There was like a panic, okay, because it was just, everyone thought it's just a matter of time, it's coming. So, yeah, there was no investigation. The day after it came out that she was got Ebola, CDC chief, there must have been a breach in protocol. So, not really. So as a safety professional, we don't blame the victim, okay? And we certainly don't announce the findings until we've actually done a root cause analysis. But we didn't do that with Ebola. We just blame the staff, we blame the hospitals. The reality of it is, if you look at the experts, there seems to be a unanimous consensus that it wasn't that there was a breach of protocols, it's that the protocols were terrible, okay? The protocols the CDC put out were terrible. The PPE recommendations they had were woefully inadequate. This is what they recommended for Ebola, okay? Far less protection than the people treating patients with Ebola in Africa were using. They were using more robust controls in Africa than here. This is what CDC said was acceptable. This is what CDC uses when they work with Ebola in a lab, okay? And this is what they said our healthcare workers can wear, okay? A little bit of a difference there. You know, they're using moon suits and they're using containment hoods and they're dealing with mLs of Ebola. We're dealing with gallons. The average Ebola patient in the United States lost anywhere from 1 to 2.5 gallons of fluid a day. Explosive diarrhea, projectile vomiting, and you're telling me that that's acceptable. Well, why is that a problem? Hair completely uncovered. You got people coughing fits, spewing blood and infectious viral loads, and we have no protective covering on the head.
we have the skin all exposed, the neck fully exposed. This is CDC said this is what you wear. Pants, no fluid-resistant pants, no shoe coverings, nothing like that. This is all government approved, okay? So I get a little bit on my high horse here because this irritated the crap out of me because this was obvious, and I felt that they were totally lackadaisical and or incompetent in their handling of that. Then after we realized and they were called on the carpet for it, they did significantly, markedly increase the PPE recommendations. So there's a handsome model with the PPE. No. So that was me. I will say Ebola took my every waking moment from that October through that January when we finally got certified as a CDC designated Ebola treatment center. It was just not myself alone. I mean, it was an army of folks here from infection control, emergency preparedness, senior leadership, getting the resources, getting DOH to fast track approvals. Luckily, it seemed to fizzle out. I'm not going to give the government credit. I think it was more luck than it was strategy that controlled that outbreak. This is not what we're used to dealing with in healthcare. Okay, I can tell you this kind of containment. We built all sorts of process controls, negative pressure rooms, protected corridors. The volume of waste you deal with when you're dealing with an Ebola patient is massive. So you had to build waste treatment rooms, and you could fill them up with 6 to 7 barrels a day. Thankfully, we didn't get an Ebola patient here at Lehigh Valley Hospital, and I'm very relieved about that. Some people, oh, we're ready. I don't think you're ever ready for that, okay? I really don't think you're ever ready for something like that. Things what we did, like we found as we were mock demoing Ebola patients, they go into the bathroom, and everybody's habit when they're in the bathroom, these are fake patients, but everybody's habit is to flush when you're done. Well, we didn't want to do that. The water authority wouldn't let us do that. We had to treat the water first with bleach and such. So we disconnected the toilets and put push buttons so they could not be activated in the bathroom. The staff members had to actually activate the toilet. So I'm going to wind it down here. So that was just my experience and my opinion. So that does bother me. Speaking of flu and pandemics, reminder there are going to be free flu shots out in the hallway after this meeting. So if you could just grab a couple shots and no flu shots today. Just kidding. Okay, winding down. All is not lost. While the national rates have been going down, we're pleased to say here at Lehigh Valley Hospital, through strategic deployment of the hierarchy of controls, we're doing pretty good. I still see way too many people injured, but while the national benchmark's at 5.7 total recordable injuries per year, we're at 2.9 now. And how do we do that? Things like safe patient movement initiatives. You can see our ceiling lift and ergonomics programs have been very successful reducing lifting, pushing, pulling injuries to staff members. There's one of our new lifts. No. People think ceiling lifts are new technology. This is actually a 100-year-old picture. So ceiling lifts were conceptualized at least 100 years ago here in America, and they didn't really become in vogue. Most hospitals around here still have no ceiling lift. They might have a Hoyer lift down the hallway in a closet that never gets used. We have almost 90% coverage of our patient beds with ceiling lifts at this campus in Cedar Crest, and some of our newer hospitals we have to redesign and work on. But so winding down, that's one of our new rooms. Other technology like beds, when we have bariatric patients, we have beds now that contort and actually will help elevate the patient out of bed. So there's a lot of controls that you can deploy and see significant improvements. We've shared our journey of our successful safe patient movement program in international journals. If you need an industrial hygienist, if you're dealing with challenges, there's a website from the AIHA, and I put the link there. So if you're like, I need a consultant, I'm dealing with a perplexing problem, please, I think industrial hygienists take a very systematic approach, and I think you'll be pleased with most industrial hygienists that you would hire. So they have a list there of consultants that are members of the AIHA. And that's about it for me. So sorry, I went a little long. But if you have any questions, I would be more than happy to entertain them. And if you're not comfortable speaking in front of a group, you can certainly reach out to me afterwards or via email or in person here. So any questions? No questions on the chat? Okay. Did everybody drop off the chat? No. Snooze. No. So, okay. Well, I do thank you for having me here, sharing a little bit of my experience, and greatly appreciate the opportunity to come speak with you. So. Thank you.
Real quick, and we do need you to come up here. For those on the WebEx, Scott Schimandel from OSHA is coming up for a couple updates. Okay. It picks up on the laptop, so.
Okay, so just leave the slide as is? That's fine, we're not using anything. Well, good morning, everyone. Real quick, I want to thank Tim. He did a fabulous job from industrial hygiene perspective. It's something that we, obviously, as an agency, deal with as part of our routine, our normal jobs. And I appreciate the what keeps you up at night process. I think that that's an outstanding effort to consider. Every safety committee should probably take liberty of doing that. The other question I always tend to like to use for safety committees is just simply asking, where is our next injury going to occur? And it'll be interesting if they give you an answer quickly. Because if they do, then something's been bothering them, or there's some activity or effort that really needs to be taken a look at, and have the team take liberty of assessing and addressing that particular issue. A couple of quick items on our plate at this point, our agenda. Agency is particularly targeting, and again, I get a feel from this audience looking at it this morning, we're not dealing with construction, but one of the priority goals of our agency is trenching and excavation work. So our agency is truly targeting and addressing excavation work at this point. It's a priority of ours. If you have taken a look at our website lately, there is a new request for information, and this may deal with many of you here. We are looking at re-evaluating our power industrial truck standard. It's somewhat dated, nearly, I believe, 50 years. But we're requesting information from users of power industrial trucks on lots of different issues, the type being used, the service, the maintenance, seatbelt usage, traveling, and the agency through, I believe, middle of June will be collecting information from anybody willing to supply that data to help us formulate where the standard may go in a rewrite. Again, keeping in mind with record keeping, most of you probably should have already submitted your OSHA 300A data electronically. That closed on March 2nd. I did play this morning just to see if I can get on the ITA, the injury tracking application launch page, just to see if it was still available. It seemed to be available this morning. The system is still collecting all the data, so if you haven't supplied it, you may want to try to see if you have luck in getting it in the system. Otherwise, just make sure that if you did not have luck, because I do know Friday, March 1st, it appeared that a lot of companies were waiting for the last second to put their data in, and the system just kept spinning and spinning and spinning. And if so hopefully if that was a struggle of yours, you took liberty of printing the page, or at least capturing that page, so that if one of our inspectors stops in and looks to see whether or not you've submitted the data, you can at least show something in your efforts to get it in. But again, the electronic submission may be closed. I'm saying may because you may still be able to attempt to put it in if you had not. Also, 300 logs, right? So we're still supposed to keep them posted through April, right? Our 300A should still be up for employees to look at if they need to. Couple last quick items just to make you aware. OSHA does have quite a few campaigns that we're part of. Coming up, well, I believe this month still might be National Ladder Safety Awareness Month. With the National Safety Council and all that, so excellent opportunity and effort to make sure that anybody who does work with ladders, we take liberty of doing some training and inspections and things like that. National Work Zone Awareness Week is coming up in April 8th. So again, we're going to start to see the weather's finally breaking to the point that, not that we haven't seen construction work going on religiously in our area here, but you're going to see more and more of it. So just be aware of those working on the road. We have a fall prevention stand down in May. We have a heat illness prevention. We used to do a campaign, a long week campaign for heat illness prevention. Now it's a No Fry Friday, the Friday before Memorial Day. So we dedicate a day that's called No Fry Friday. So again, during that time period, it's a wonderful time to kind of orient everybody about heat-related illnesses, and not just outside. Obviously, there are a lot of industrial operations and activities that we do have elevated heat levels, so we should be aware of that. We have trenching coming up in June, and then we have a fairly aggressive, which I love, a safe and sound campaign. So in August, we try to make sure that companies take liberty of conducting workplace inspections a little bit more rigorously and get the employees engaged. And safe and sound is literally that effort to find hazards, fix hazards, report them, those kind of things. So a lot of companies take liberty of trying to incentivize activities to get employees engaged to find hazards in the workplace and then have them corrected and put on a tracking list. Last but not least, if you had not already seen, unfortunately, I'll say it that way, unfortunately, our fine structure has gone up again. So, you know, a typical serious violation is just over $13,000 for one item. So, you know, just be aware our fine penalty structure is based on cost of index, cost of living index is being adjusted accordingly. So that went up as well. Other than that, Scott, Dr. Dolphin, I have nothing else at this point in time. Thank you for the opportunity.